Okay, good morning. I think we got to mute. All right, we're working on the feedback here. Thank you. So welcome to Grand Rounds on this lovely fall day. So hopefully all of you are staying warm and dry. And I'm delighted to first introduce Dr. Jain Wright from our Division of Cardiology to introduce our outstanding guest speaker, Dr. Jain from Northwestern. So Jen.
Thanks, Dr. Schnapp. Yes, happy Friday, everybody. It's good to see people in person. I have the honor and pleasure of introducing my friend and colleague, Dr. Bijal Jain, for today's visiting Grand Rounds. Dr. Jain did her undergrad at Loyola, followed by medical school at UIC in Chicago. And then that's where we met at Northwestern for residency. Post-residency, Dr. Jain took a position at the Beth Israel Deaconess in Boston, followed by going back to Loyola, and then finally back to Northwestern. It was at Northwestern that she then took on more of a full-time role at the Jesse Brown VA. And that's where she's really shown when it's come to her leadership in diversity, equity, inclusion, education, and in quality. So currently, Dr. Jain is the director of the site for the residency at the VA. She's also the co-director of the point of care ultrasound program at the VA. And also she's been an integral member of and co-chair of the Jesse Brown for Black Lives Committee, whose purpose is to combat racism in medicine and advance the healthcare for veterans. It is through this effort that Dr. Jain and her colleagues have received national commendation for their work. For not only the patients at the Jesse Brown VA, but also the patients nationally at the VA. So it's with this experience she comes here today, and we're very fortunate to have her to present on the pitfalls of the race-based hypertension guidelines. So without further ado, welcome Dr. Jain.
Thank you, everyone, and thank you, Dr. Wright, for that warm welcome. I am delighted to be here today to talk about this very important topic on the pitfalls of race-based hypertension guidelines. Let me just make sure that this, my disclosure slides and then acknowledgement statement. And so my hope is that by the end of the presentation today, participants will be able to classify race as a social construct without a biological basis, list at least 3 factors that contribute to the disparities that we see in hypertension and related outcomes, appraise the evidence for race inclusion in current hypertension practice guidelines, and finally identify at least 2 equity-focused strategies for hypertension that are aimed at mitigating disparities. And as Dr. Wright mentioned, I work full-time at the Jesse Brown VA, where more than 50% of the patients we serve belong to the Black community. And so this topic of health equity is very important for us. And Dr. Wright also mentioned my membership and to the Jesse Brown for Black Lives committee, of which I co-chair the Clinical Algorithms Committee. And a lot of the work that I'm going to share with you today is the collective effort of all the members of this committee. And so I'd like to begin with a patient case. So this is patient A. She's 31 years old. She was diagnosed with type 1 diabetes at the age of 21. This is patient B. She is also 32 years old and was diagnosed with type 1 diabetes at the age of 21. And really share a lot of the medical history and lifestyle, the only difference being that patient A identifies as Black and patient B identifies as white. And so both patients have recently noticed that their blood pressures have been running high. They follow up with their primary care doctor, who recommends lifestyle modifications, which they do, and now they're here today at their 3-month follow-up. And the question is, how would the PCP approach each case based on the current guidelines? And why are we even having this conversation today? I think it's well known that there are significant disparities when it comes to hypertension. Black patients have a higher likelihood of having hypertension, earlier onset, faster progression, and more likely to have treatment resistance. hypertensive Black patients are also at higher risk for all the end organ damage and cardiovascular mortality that results from uncontrolled hypertension. And so when we think about many of the most important diseases contributing to morbidity, mortality today, it's really hypertension that's the main contributor, and it's a modifiable risk factor. And we know now that with 2 to 3 medications, up to 90% of hypertension can be controlled. And so that brings the question, what are we missing and why these disparities? And so a group of brilliant investigators with the right intentions sort of asked the same questions a few decades ago. And one of the things that they were considering was, is it possible that because of the historic underrepresentation of Black patients in medical trials that inform our clinical practice, could that be one of the reasons? And so what followed was diligent recruitment of a diverse population, and there were 2 large-scale randomized trials that were conducted that had increased representation from the Black community. And these are the 2 trials that I'm going to talk about today, which are the ALHAT trials and the AST trials. And I would say the observations from these trials led to conclusions that really greatly impacted the subsequent guidelines, of which I'll present to you the JNCA guidelines published in 2014. And as you can see over here, for the very first time, Black was incorporated into the algorithm. It was actually a branch point for the initial therapy. And what the justification here was that Black patients respond less to ACE inhibitors, and that Black patients have low run-in states, and thus they should really not be treated with ACE, but rather calcium channel blockers or thiazides as first line. So the question is, okay, these guidelines came out, are we following them, and sort of what's the impact? Did we achieve our intended outcomes? And Dr. Holt kind of looked at this question. He analyzed EMR data from a couple of years, and this is in San Francisco Bay Area, so kind of limited to that population. But he analyzed the data, and what he found was that, yes, in fact, doctors are following the recommendations in the sense that like Black patients are much less likely to be prescribed ACE inhibitors. What he also found was that Black patients still were much more likely to have uncontrolled blood pressure. Looking more at the national population level data, the NHANES database gives us an opportunity to compare blood pressure control in the US population between different time periods and also according to race. And so in this study, the comparison really was from the early 2000s to 2015 to 18, sort of pre-post the guidelines. And what they basically demonstrated was the same thing, that Black patients still shared a larger burden of uncontrolled blood pressure and not meeting their goals. So that's the question, you know, what are we missing? Have we missed this target? The studies that were done with the intention to mitigate disparities led to actions that not only did not help, but as I'm going to be talking about, actually led to exacerbation of these disparities. And so the remainder of the talk is more or less going to follow the objectives I mentioned earlier. And they're kind of be broken down into 3 sections, but we'll bring it all back together at the end. So if you look up the definition of race in the Encyclopedia Britannica, the first statement that comes up is the idea that human species are divided into distinct groups on the basis of inherited physical and behavioral disturbances. And it's this prevailing thought that has really guided much of the use of race in clinical medicine in the history of medicine. However, in 2003, after 2 decades long work by scientists from all over the world, we finally learned what the Human Genome Project revealed, which was that human beings share 99.6% of the same DNA. We also learned that any variation that we do see has happened over thousands and thousands of years, gradually and continuously over geographical space. The factors that go into some of these changes are genetic drift, and random mutations. And you guys are not here for a genomics lecture, but I think these concepts are really important as we think about some of the genetic variants related to hypertension. So these random mutations, oftentimes they're just silent. Sometimes they do confer a survival benefit, and thus are kind of selected through natural selection. So as all human beings originated from Africa 400,000 years ago, as they migrated to different areas of Africa, what we saw over time was that within Africa, there were distinct groups with distinct genetic traits according to their environment. And this is a really important fact because we now know that there is more genetic difference between populations within Africa than there is between populations, say, in West Africa and Europe. And so we're talking many, many thousands of years ago. But what about today? So today, as we look at our melting pot and people are traveling everywhere, what we have is genetic admixture as a result of interbreeding between populations. And over time, this genetic admixture leads to what we call ancestral diversity, meaning each one of us contain a mosaic of ancestry that is really not able to be decoded by someone's race or skin color. And I'm going to demonstrate this concept to you in the next couple slides. And so this is Ashley. Ashley is one of the participants in the DNA discussion project out of Philadelphia. And her information is posted on their public website. And so Ashley identifies as Black, much like our patient A. However, if you break down her DNA, you can see over here that majority of her DNA is actually from Europe and only 29% is African. Really bringing home that race and ancestry have no correlation. When you even look at what it means to have African ancestry, we already spoke about within Africa, there are distinct populations with distinct ancestries. And so when you just say African ancestry, it really doesn't mean anything. You really have to know West African, East, South, because they're very distinct. And as they spread across North America, South America, you can see that there is also a lot of diversity in the makeup. And to note that people from Central South America may not even identify as Black, but they will contain a significant portion of ancestral roots to parts of the Africa. And so this last case is really speaking to that final concept about the genetic mosaicism that we embody. So these are 3 of the thousands of scientists involved in the Human Genome Project. As you can see, Watson and Venter would be considered to be of the same race, whereas Kim would be considered to be of a different race. However, when you actually look at their genetic makeup, what we find is that Watson and Kim actually have more genetic similarity. And so really, what are we talking about when we say race has a genetic basis? Absolutely nothing. What we also know now is that there is significant more variation between people than there is between populations, even from the same ancestral regions. And a part of that is because of genetic polymorphism. So that stands for when there's multiple genes, and depending on the combination of genes, you'll have a certain phenotype. And many of these polymorphisms occur just because of a substitution of a single nucleotide called SNPs. And then also polygenes. These are important because almost every complex disease that we think about today, cancer, diabetes, cardiovascular disease, hypertension, is governed by multiple genes. And many of our physical characteristics that we observe, such as height, eye color, skin color, is also a result of multiple genes that are interplaying and resulting in a phenotype, which is why you actually end up having a kind of a continuous range of phenotypes. And so ultimately, what is really important to think about is that despite whatever our genetic makeup is between people, individuals, what impacts the phenotype, the final phenotype, is really the interaction of your genes with your environment. And that happens in a few different ways. For instance, there are some polymorphisms where if you have both of the alleles, you're considered high risk. And for the nephrologist in the room, you might think about ApoL1, for instance, which portends a much higher risk for kidney disease and end-stage renal disease. So even in those patients who have those two high-risk alleles, only 15% of them end up manifesting the phenotype. Why? Because there's a huge component of involvement from the environment, and we often refer to that as the two-hit hypothesis. Another field that's sort of related is the emerging field of epigenetics, and the premise there is that environment and behaviors can influence the way our genes are read and expressed. So it's not about genetic changes, but it's really about how our genes express themselves. And I'm saying all of this because I want to really emphasize that when we speak about hypertension, all of these components are in play. And so when we're thinking about disparities and we're thinking about treatment, all these components are going to be in play. And before we move on, I wanted to actually present this figure to you. This is mapping out the variation in skin tones globally. And I thought this was really interesting because, as you can see, the differences in skin tones are sort of varying with how close they are to the equator. So the further you move from the equator, the lighter the skin tone. And the story behind this is that 400,000 years ago, when we were all in Africa, where there's high sun exposure, the sun was breaking down folic acid, causing birth defects. And so arose a mutation that led to, or several mutations that led to darker skins, and that prevailed. Then about 10,000 years ago, as we started to migrate out, we faced another problem. As people moved away from the equator to areas of low sunlight, their problem became vitamin D. And so independently, many mutations arose that conferred lighter skin. And in these areas of low sunlight, because that helped with vitamin D absorption, those persisted. And so when we think about our skin color that we often substitute and use to assign race, really it's an interplay between vitamin D and folic acid and the amount of sun that's around, and has not much else to do with anything. So race, what is it? You know, we all know now that it is not inherited, it is not a genetic biological construct. What race is a manufactured way of grouping human beings into hierarchical systems, essentially. It was created during times of enslavement, and it was really to maintain socio-political, economical, and health superiority by white enslavers. Race, as we define it, is very dynamic. It depends on where you're born, depends on where you're traveled to, and even in the US, you can see over the decades, the definition of race has evolved. As it stands currently, 10% of the US population identifies as biracial. We're going to talk about racism, and racism is the system of structuring opportunity and assigning value based on the social interpretation of how one looks, that unfairly disadvantages some individuals and communities and unfairly advantages some individuals and communities. And we all know that racism penetrates through every level of our society, really starting at the top from the systemic level. And we are learning more and more that it's really racism and not race that has the greater adverse impact on health. So what are we doing when we are using race as a biological variable? We are subscribing to the notion of biological determinism, and we're perpetuating the notion of scientific racism. And that's the belief that there are biologic or genetic differences between races, and that makes one race superior to another. And so for those of you who have not read this article or are new to this conversation, I recommend this very insightful article by Dr. Vyas, published in the New England Journal of Medicine a couple of years ago. This was one of the first articles I read, and it was phenomenal. The reason I put this table up here is because this is just a partial list of all the areas in medicine today where race is used to factor into clinical decision-making. Dr. Vass proposes 3 questions, sort of a framework, as we're sort of interrogating the appropriateness of including race into our clinical decision-making. She asks, is the evidence robust, meaning are there any biases or all the confounders sort of accounted for? Is there a plausible biological explanation? And finally, will the inclusion exacerbate disparities or actually mitigate them? And so as we move on to the second part, which is what are the causes of disparities that we are seeing that do fall along racial lines? We've talked about how hypertension is multifactorial. It is driven by our neurohormonal system, by inflammation, by genetics, and by the environmental and lifestyle factors. And along the same lines, when we think about health disparities, it is also multifactorial. And I'm going to argue that the biologic and genetic component is actually very minor. And it's some of these other things that we need to really be thinking about and focusing on. And so here's just a sample of all the articles that are coming out on a regular basis of new genetic variants that have been discovered that are related to hypertension. But for all the reasons that we've already discussed, which you all know now, we know that this is going to be very variable between any 2 individuals and has absolutely nothing to do with populations. So ultimately, the impact is really unknown. Epigenetics was the other thing that we had discussed, and this is actually an important thing to keep in mind, because we now know that environmental exposures to different pollution levels and toxins in water, et cetera, which do tend to occur more frequently in disadvantaged communities. These all can have an impact on epigenetic modulation, and we've identified several foci that actually are correlated with target end organ damage related to hypertension as a result of the epigenetic modulation. So that is a cause of disparities that we have to keep in mind. The other cause of disparities is this concept of an allostatic load. Allostatic load is the totality of all the biophysiological dysregulation that occurs to our body as a result of a chronic exposure to stressful conditions. And again, there's a lot of studies that are coming out that the stress, trauma, discrimination, and vigilance that Black persons face in today's society due to racism leads to higher allostatic load in that community. And the impact really in terms of hypertension is that with increasing allostatic load, you have dysregulation of your neuroendocrine immunoinflammatory system. So basically dysregulation of all systems. And you're not really able to respond adequately to future stress, or you're not really able to shut it down. And this is related to another cause of disparities, which is nighttime phenotypes of hypertension. So we always think about high blood pressure during the day, and very commonly our blood pressure drops during the night. What we've discovered is that there are nighttime phenotypes that are very much correlated with increased cardiovascular mortality. And these are basically at nighttime if you don't have a dipping status, so those are called non-dippers, or if you have a reverse dipping at night, which is known as like nocturnal hypertension. And so both of those have much higher morbidity mortality. And it turns out that Black patients, Black men and women, have are more likely to have these nighttime phenotypes. And why this is important is because studies have also shown that people who have these nighttime phenotypes, about a quarter of them during the daytime are actually going to have normal blood pressure or even low blood pressure. And so the disparities there are when we use clinic blood pressure or daytime blood pressures for diagnosis, or we use it for titration for management, then we're really missing this group of patients who are at already a higher risk from this high-risk phenotype. And finally, I think we all are aware that there's a big impact of social determinants of health on our health in general, but this is a nice study that actually puts it down, puts on some evidence on it. And this was published just a few months ago, actually. And what they basically concluded was that social determinant health accounts for 33% of the difference in blood pressure control. And these were the factors that they identified. And so to sum up, kind of as we're thinking about what are the causes of health disparities, well, it is not the race, and it's not that people of one race respond differently to one group of medication. Really, the cause of these disparities are all these other factors. And if you think about each one of them, they're really rooted in racism. And so for this next section, I'd like to take a look at some of the studies and the evidence and where we are today. And before I actually get into that, I wanted to point out that a lot of the studies that were done, brilliant investigators, all the right intentions, we have to acknowledge that there was an overlapping timeline with the Human Genome Project. And so I think I have a lot of respect for all the work that they've done. And the only way I can sum it up is that we didn't know then what we know now. And so with that, the ALHAT study was a very large trial of 33,000 people, US adults with hypertension, and of which 35% of them were African American. And this was really meant to be a monotherapy trial comparing 3 drug classes, ACE inhibitors, calcium channel blockers, and chlorothalidone thiazides. And patients were followed for 4 years, average of 5 years. And what the trial showed basically was that as far as primary and secondary outcomes are concerned, there was no difference. With the subgroup analysis of the secondary outcomes, there was some statistics that were concerning. One, that ACE inhibitors were less effective in Black patients, and 2, that ACE inhibitors were correlated with a 40% greater risk of stroke and a higher risk for heart failure and combined cardiovascular disease. And so I'm giving this over here because the next thing I'm going to do is go through some of the criticisms that have been kind of published about the trial, and take you through why we may have seen some of the outcomes that we did see. And so when you think about the fact that it was meant to be a initiation trial and a monotherapy trial, 90% of these patients were actually on prior blood pressure medicines. We don't know if they were on 1, 2, 3, but they were on a lot. And at the time of randomization, they were abruptly stopped and then switched to a monotherapy. And so both from an initiation standpoint and a monotherapy standpoint, it doesn't really fit our current standard of practice. And beyond that, more than 2/3 of the patients by the end of the trial were on 2 or 3 drugs. So again, really, when you're thinking about monotherapy, not sure we're dealing with monotherapy at the end of the day. The step-up therapy was really not what we think of as current standards. So it was a Tylenol, clonidine, risperidine, and so it's a lot of the meds that we really wouldn't use. And so that right there also makes it really not applicable to how we would practice today. And the other small point I did want to bring up is that if you think about hypertension having multiple pathways, and you think about it being driven by sodium and volume, and then renin-angiotensin, and most people, they might have predominance of one of 2 influences, but really there's a lot of overlap. And so if you think about how you want to treat them, you usually want to give them medicines that come from 2 different classes. And the choices that this trial had for step-up therapy for the lisinopril group, there was no choice for being on a diuretic or a different mechanism. So that right there kind of stacks the cards against lisinopril. And then finally, the intention to treat analysis, which is very respectful and rigorous and wonderful, but you almost wonder if for this trial it was too rigorous. And I've already mentioned that, by the end of the trial, most people were on 2 or 3 drugs, so you really don't know what you were comparing. But other things to note about this is that about 1/3 of patients actually discontinued or had crossover. And actually by the end, only 20% of the chlorothalidone group was not even on chlorothalidone. And 30% of the group was actually on a beta blocker. So some people have argued, like, really, what drugs have we been comparing in this trial? So the next things, the conclusion of these trials were that ACE is harmful in Black patients and that chlorothalidone is superior. And both of these are sort of really based on kind of, I would say, weaker evidence considering everything we just discussed. And the other big thing we want to know is that this trial was powered to show a difference in primary outcomes, and it did not show a difference. And so really taking the subgroup analyses of secondary outcomes with a grain of salt there. And this idea of ACE not being effective or being harmful really contradicts multiple other studies. And the statement that chlorothalidone is superior, I love thiazides. I think they're great. I think they're super effective. But I'm not sure I can go as far to say that it is superior to all the other medications that are out there. And so, just to kind of look a little bit more into why the data ended up showing what it did for the chlorothalidone group. This is a study by Dhruva and colleagues from 2017. And they took all the ALHAT data and they actually analyzed it looking at all the same outcomes, but more as people who were immediate responders in terms of blood pressure control and people who were non-immediate responders in terms of blood pressure control. And you can see from the graphs here that even by month 1 and 2, there was already separation. And so whatever these end outcomes were, the differences really started showing up very early on. And we know that in order to impact stroke and heart failure, that's not a 1 or 2 month thing, okay? So what the authors here concluded that really it was the early control of the blood pressure that led to the improved outcomes. And why that was more in the chlorothalidone group, one of the ideas here is that a lot of these patients who were on multiple medications or had high blood pressure, when they were abruptly stopped, perhaps they had rebound hypertension. Perhaps they were on diuretics before and they were put back on diuretics. And so you can imagine where the chlorothalidone group had a little bit of an advantage for that immediate response over there. And when we were actually looking at the same trial and you want to look at who were the non-responders that didn't have the benefits from the hypertension management, we can see over here that the non-responder group did have more patients who were Black, but it also had patients who had higher blood pressures at the time of randomization, and these patients had more LVH. And these patients during the trial required much more aggressive titration and additional medicines. So in reality, it's really the high-risk patients that were non-responders. And the takeaway there should be that we should be treating everyone aggressively and trying to get blood pressure control soon. So, from a big picture kind of standpoint to wrap up the ALHAT trial, the monotherapy algorithmic approach assumes that all blood pressure is homogeneous, and that's just not true. And it also assumes that there's a biological basis to race-based treatment, which is also not true. And finally, it really missed accounting for social economic factors and social determinants of health. The other trial I want to mention over here is the ASK trial. ASK trial was conducted around the same time, and it enrolled all Black patients, about 1,000 of them, who had advanced CKD. And what they were looking at, it was a 2x3 factorial design, and what they were looking at is the impact of intensive versus usual, or these 3 different drugs on renal endpoints such as GFR slopes and kidney failure and mortality. And what they found in each case is that ramipril is superior to the others, and this is in a Black population. And that they also found that the blood pressure really didn't matter between intensive, but that comes with a caveat because later follow-up showed that it did have some impact on patients with proteinuria. But the takeaway there is that ACE is good. It's not harmful. Other notable studies I wanted to just quickly highlight because it creates the evidence base as we talk forward about how we should be managing our patients with hypertension. The trials all the way at the top, they were all predating the ALHAT trial. But each one of them, so the caveat there being that there was not as much representation from the Black community, but the takeaway, each of those trials showed that ACE inhibitors reduces target organ damage and cardiovascular mortality. The value trial, a post hoc analysis of it, showed that once again confirmed what Dhruva and colleague found was that achieving blood pressure control early aggressively is more important than the type of drug. The accomplished trial said that combo therapy ACE with calcium channel blocker ACE thiazide improves MACE. And finally, the SPRINT trial, I think a lot of us are familiar with, showed that more intensive control of blood pressure does improve outcomes, but then there is also more side effects. So really depends on the patient and situation. So why is this important? All these studies I just told you, and I offered you all this evidence about ACE inhibitors. Because a prevailing thought to justify the current guidelines, as I said, is that Black patients have low renin. And that is why they don't respond to ACE inhibitors. We know that's not true. And what's the harm that's happening? Because now we're talking about inequitable access to medications that are potentially important. And what we have learned is that ACE inhibitor is not only important from the blood pressure standpoint, but a lot of the tissue-mediated pathways that lead to target end organ damage are mediated by renin and angiotensin II. And in patients who have low circulating renin levels, it's not uncommon to actually see high tissue renin levels. And it's really the tissue renin levels that contribute to the target end organ damage. And really, more so than the blood pressure goal, that is our goal, right? The tissue and the cardiovascular mortality. And so that just kind of builds the case that ACE inhibitors are useful drugs regardless of what impact they have in that one individual on their medications. They help with pleiotropic benefits. And this has been supported also by many other trials, as we've already discussed. And so when we are using our current guidelines and we are not giving ACE inhibitors as first-line treatment to Black patients, what we are really doing is having inequitable access and really making our disparities worse. So what does the current evidence show? How should we be treating our patients? Is monotherapy the way to go? Should we be changing our approach? And what's interesting here is that the same NHANES database we had talked about earlier, when they had done another analysis in 2009, 2010, they had actually shown that from 2000 to that point, there was actually improvement in blood pressure control in all groups. And then the subsequent analysis, we pretty much took a step back. But in that 2009, 2010 analysis, one of the big factors they had brought up was the use of combination therapy. And since then, multiple trials have basically shown the same, that combination therapy right up front is far more effective and can lead to much better rates of sustained blood pressure control. It also reduces the heterogeneity that occurs from individual to individual. One of the studies have actually shown that when you use combo therapy of two different mechanisms, it actually is synergistic, and the efficacy is like 5 times greater. And then you can get away with lower doses. And so lower doses, it means less side effects, right? And one of the biggest factors that have been identified for preventing us from gaining better blood pressure control is really physician inertia. And I wrote over here, inertia also by patients, because it really makes a dependence on the patient for following up. But physician inertia is really important because it leads to failure of adding new therapies, switching therapies, et cetera. And so in the case of our Black population who are not getting ACE inhibitors as first line, who are at higher risk, this could very much lead to even delayed initiation of therapies like ACE inhibitors. And then with more and more single pill combinations that are available, if that is an option, that is obviously a really great choice because it can improve patient adherence as well. So recent guidelines, I'll review 3 of them. 2017 ACC/AHA guidelines do acknowledge that most patients should get 2 or more medications, and they identify Black patients at particularly higher risk, and you should be considering 2 medicines for them. They're a little bit kind of off because they still in their first recommendation say that Black patients should get calcium channel blocker and thiazide. So it still kind of implies that there's some race-based differences in treatment response, but they're getting there. The 2020 International Society has no mention of race. They just say start dual therapy. And very recently, European guidelines basically have a very strong recommendation that all patients, even mild hypertension or stage 1 hypertension, really should be started on combo therapy upfront. And really, it's like the frail elderly or the very, very mild ones and patient preference where you should be thinking of monotherapy. The other big change that the ESH guidelines made was a strong recommendation for using 24-hour ambulatory blood pressure monitoring. And I think that's really important as we're thinking about mitigating some of these disparities, because it's really the 24-hour blood pressure monitoring that's going to help us pick up those nighttime phenotypes that are very high risk. And so moving to the final part of our talk here, I promised that I would help you, that I would provide some guidelines as to how we can move forward in a more equitable path. And just wanted to loop back to our patients A and B, and how would we manage their blood pressure. And so from everything we've discussed today, I hope that the PCP is not using race to make treatment decisions. I hope that the patients will be tried on initial combo therapy that includes an ACE, and that they will have aggressive screening for target and organ damage, for social determinants of health, barriers, side effects, everything. And I'm going to talk about some of those in a little bit. So we talked about racism and really playing a big role in all those different ways that healthcare disparities occur. And the fact that really starts at the systems level with the policies that are in place. And so in July 2022, the Biden administration did propose a new rule to Section 1557 of the Affordable Care Act. And this rule specifically prohibits providers from who receive any federal funding for whatever that's worth, but to discriminate based on protected traits such as race. And they make a special mention of race-based clinical algorithms. I don't really know if many of you are familiar with this, but this is really a giant step forward. However, sadly, we're not really seeing it, this being translated to our practices right now. And part of the criticism that has been noted is that really this offers no guidance. It kind of leaves the onus on the physicians to sort of decide, and they just feel kind of more or less helpless because they are just trying to follow national guidelines, and now this law makes it on them to sort of make that decision. And so I had mentioned to you earlier that Dr. Vyas mentioned the framework of those 3 questions for anytime you're considering the inclusion of race in clinical algorithms. So for the case of hypertension, per se, if you were to apply that, the first question is the evidence robust, and does it account for all biases and confounders? And I hope that we all can agree from what I've told you that it's not the case. For the second one, is there a biological explanation that's plausible, that justifies the use of race? And again, I hope that we can all agree that that is not the case. And finally, will incorporation of race into that clinical algorithm mitigate disparities in outcomes or exacerbate them? And again, for that, I would say that the current guidelines would be exacerbating them. So as we move forward and we're thinking about, well, what can I do from our perspective, even in your personal practice or even as an institution? And I think one of the things that I found confusing initially is, I'm coming up with all these ideas, but what do they really mean? Like, where is it going to make a dent? And I I had read through Ibram's Kendi's book, and I know there's a lot of controversy behind it, but he is very big on definitions. And I found 3 definitions to be really helpful for me, at least when I think about my actions and what they represent. The first one is racial justice, and racial justice is removing race categorization from where it never belonged. So just making things fair. The second one is anti-racism, and anti-racism is combating policies and practices that exacerbate health disparities. And the last one is positive racial discrimination. I know we don't like to use the word discrimination, but in this case, positive racial discrimination really means actions and policies that will build equity, that will actually build equity. And we, I don't know if this is familiar to many of you, but there's different iterations of this in the web when you think about equity and equality. I liked this one because you can see the 3 boys are the same. Usually when you see this graph, it's like maybe a patient with disabilities or different heights, or there's like something else about the person that is different, but here it's just like all humans, same, right? And so when we think about racial justice, oftentimes we think, hey, that's like the end goal. We want justice for all. But in medicine, racial justice doesn't begin until we actually stop using race in the wrong way, okay? When we think about equality, I had mentioned equality, anti-racist actions, I had mentioned that is actions that actually take away or dismantle things that is going to exacerbate disparities, right? And so in the case of hypertension, that would mean making sure there's equal access to ACE inhibitors, which are proven therapy for all patients, regardless of their race. It also would mean being very explicit about why you have stopped using race-based medicine. It would mean that you want to educate everyone on the harm that racism has on human health so that they can be more aware and really and screen for it. As far as our equity building, positive racial discrimination, some things to consider over there. And when we say positive racial discrimination, I mean, it's not, unlike negative racial discrimination, positive doesn't take away in order to give. It just, there's a pool and you just kind of allocate resources depending on need, okay? And so things to consider over there is maybe you have high-risk patients and they have barriers for follow-up. Let's implement a telehealth clinic. Let's have a mobile clinic. Let's have a pharmacy-run interdisciplinary clinic that only focuses on high blood pressure so that the PCP can take care of like all the other 20 problems that they come in with. Let's make sure that the care we're providing is culturally competent and takes into account their other priorities or that might be interfering. And really, at the end, I would say, we don't want to use race as a biological surrogate to make decisions, but we do want to consider race a risk factor because of everything that we've learned today. And so when we think about, okay, how can we be using race in our biomedical research, it is as a risk factor. Sometimes it can substitute for social economic class, but really it is a risk factor on its own. And so when we are making changes and trying to build a more equitable future, we should be following those demographics to make sure that we're actually heading in the right direction. And so with that, these are my take-home points, and I thank you very much for having me. I just wanted to make a quick shout out to my patients who are absolutely wonderful, and it's a delight to be working at the VA. The Jesse Brown for Black Lives Clinical Committee, who has really opened my eyes to the world and made me a better person. My mentors and colleagues, Dr. Wright, for having me here today, and of course my family, who has been very patient with me.
Thank you so much, Dr. Jain. That was just a wonderful talk. I learned a lot, and I'm sure that everybody in this audience did as well. We do have one question here from online, and then I'm sure we can have some questions from the audience as well. So the question online is, given the difficulties of BID and TID meds for even the most privileged of us, are there any efforts to see if monotherapy or QD combo therapy has had more success for communities with lower socioeconomic statuses?
Thank you for that question. Yes, that's absolutely right. And you're getting to the point here is that we should be trying to make sure that we have access to available single pill combinations. And studies have definitely shown that there is improved adherence from the patient standpoint. And yeah, you're right. Like even us, when we have antibiotics that are scheduled Q6, I mean, I have to say, I probably miss a dose or two a day. So that is definitely hopefully the way of the future. And if you look at the international guidelines, they really emphasize that because they're looking at things from a more resource limited standpoint. And so they really do highlight those approaches.
And oftentimes they're quite expensive too, the combo pills.
They're becoming generic now.
Okay.
Yeah.
Good to know.
There's a few that are available generic, yes.
All right. Do we have any questions from the audience? Dr. Schnapp.
Thanks. Great talk. Thank you for the overview. I was intrigued by the recommendation for 24-hour monitoring of blood pressure to determine whether somebody has hypertension or not. Would you, one, are you doing that in your practice? Two, should we be doing that to monitor response to therapy as well?
For the question, that was a great question. So the question is whether ambulatory blood pressure monitoring, 24-hour monitoring should be a part of our practice right now, and should we be using it to titrate medications? That great. So I'll tell you from my practice at the VA, we are looking at whatever ways we can actually get these devices because they are expensive. Okay. Yes, absolutely. But the way I see it is that you don't need them every single day. So unlike your home BP where you know, those you can just check here and there, but really for screening purposes and for purposes of titration, if you were to supply the ambulatory blood pressure monitoring for a patient for say like 3 months until their or 6 months until their blood pressure is controlled, then they really would have to put it on maybe for a day or two before their clinic follow-up, and you'd get enough of an idea of what their what they need for titration. And so you almost wonder, like, unlike the affordable blood pressure, home-based blood pressure monitoring devices, I think they can be like $10 or something like that. These maybe are things that actually the institution owns and sort of gets recycled between patients. And then the question for, yeah, should we be using it for titration? I think that's a really also a very good point. And you know, it brings up one of the things that we know now as we've been studying profiles of patients and their hypertension patterns. And so there's like 4 profiles that are like very like basically 4 profiles. The first one is the most common one, which is our highest blood pressure is during the day and our lowest blood pressure is at night. The second one is that you have high blood pressure during the day, but you also have like high blood pressure during the night, or you're a non-dipper. For both of those cases, it's actually okay to use clinic blood pressures or daytime blood pressures. And that's sort of what the guidelines say, because you're not going to miss anything. You can titrate according to the clinic blood pressure and you'll still be okay. It's really the patients that have daytime blood pressures that are normal or low and then have nighttime blood pressures are high. Those are the ones that get undiagnosed and really undertreated. So there could be some also triaging there of like, you know, based on the initial diagnosis.
Thanks, Dr. Jain. We have another question online. Thank you for the talk. It was eye-opening for me. I know your talk was focused on hypertension, but there's so much research about race contributing to different disease biology, example in cancer. Do you feel that the biological basis for racial differences is true in all diseases?
It's an excellent question, and thank you for asking that. And actually, it goes to part of the reason why I put you guys through the torture of the genomics lecture. Was really because a lot of the information I shared with you today is not limited to hypertension. This idea of there being more genetic variation between people, and there being multiple things that are kind of going on at the same time within your body, genetics, environment, physiologically. Like almost every disease that we can think about today is complex in that sense, and that's really the true meaning of the term multifactorial in this day of genetics. And so, yes, absolutely no doubt that some of these are contributing to increased disparities, to the observed disparities in cancer rates and diabetes and other outcomes. I hope I
Thank you.
answered that question.
Yes. All right. I'm coming. It's giving me my steps this morning. Okay.
Dr. Jain, thank you so much for coming. It was fantastic. The first is almost more of a comment than a question. It seems like one of the major lessons of all had is when you do an RCT, be cautious when doing subgroup analysis. And in fact, we probably shouldn't do subgroup analysis at all to really come with conclusions and base our guidelines. And I wonder about those chart you showed from the New England Journal article, how many of those were based on subgroup analysis, because randomization only randomizes for your primary group, not your subgroups. So it's just a comment and a caution for all of us who do trials and subgroup analysis. The second is there's an increasing term about pharmacoequity, and this seems to fall within the notion of pharmacoequity. And to me, the solutions for pharmacoequity are on a systemic or systematic basis. And so what are you doing at your institution to really kind of from a system level to help clinicians make the right decisions and to do some of the guidelines which you're looking to do?
So thank you for that question. The question is about medications and having them available in a equitable way. And is that what you from a system standpoint, how to make it? Yes. Mm-hmm. Absolutely. So, one, I work at the Veterans Hospital. So we actually are very, very lucky where we actually don't have to take into account some of these barriers of cost because our patients will get all the medicines. But say across the street, UIC Northwestern, I think, you know, we have so many medications in our formulary, and evidence shows that majority of patients will actually get their blood pressure controlled with the common 2, 3, or 4, 5 drugs. Okay. And so I think from the system perspective, at least what we are doing is making our ordering menu for physicians when they sort of like go there, you see like all these medicines, it's really confusing. And so if you make your ordering menu sort of almost follow the guidelines, like start with your combo therapy, have a guidance. And I will say like there is a wonderful example of that, the Kaiser Permanente system. I don't know if you guys have heard about their excellent work, but they did exactly that. They protocolized their hypertension approach. And what they did was initially they started with sort of the step-up monotherapy, but in about, I think, 2005 or 6, they added first-line combo therapy. And what they've shown is that blood pressure control went from, I think it was like 28 or something, I might be misquoting that, but really the end outcome is more important, which is 80%. And then most recently they published, it was 90% blood pressure control in their cohorts of thousands and thousands and thousands of people. So that is really a success story. And I think that's something we can learn from. And at our center, we're trying to also implement something like that. I hope I answered your question.
No, absolutely.
Okay. Mm-hmm.
All right. We have 2 more minutes. Okay. See another hand.
Hi, my name is Christine Sharkey. I'm a rheumatologist, but my question was about cultural competence and dietary recommendations, because you mentioned that as part of your reasons for, you know, controlling blood pressure. And I do feel from, you know, a lot of our learners and ourselves that we don't have cultural competence in the types of foods that our patients eat. And what resources do you recommend that we use? And also even helping our nutritionists in the same way. I think when the recommendations come to our patients, they're being told, eat this, do this, but that's not even in their foods that they would even eat. So what do you recommend as a resource?
That's a great question. Thank you. The question is, how can we use cultural competency to address the nutritional sort of recommendations that we make to our patients in a way that is actually relevant for them and pragmatic, right? Yes, I think that is such an important point because you have to acknowledge first and foremost if there is strong reasons for why people prefer certain foods or certain activities or whatever not. You have to take that into consideration, and trying to just be on that, laser focus, like you must stop that, is really not going to be practical. All it's going to do is lead to them not doing it. And so if you are, if you have patients who you're going to be giving this nutritional advice to, the recommendations need to be kind of what is actually available to them and what they like. And that goes back to, like we talked about, having the interdisciplinary, like say pharmacy run clinic, having someone there that is dedicated just to that part of it, so that it's not just part of like a busy like primary care physician's practice. I do think also, when we think about sodium and like high sodium diets, I mean, some of that is not really it's kind of depends on your socioeconomic status, and it's not immediately preventable. So, well, use diuretics, I mean, people use the argument that, oh yeah, because when you eat high salt, you end up having low renin and then you don't respond to ACE. And there is some truth to that. Your ACE inhibitors do become a little less effective, but all of that is offset by using diuretic and use a combo. And so, like another kind of vote there for combo therapy. But yeah, I don't know if I answered your question, but I agree with you that you have to really consider the patient and what they have available and their preferences when you are making these guidances, and having someone that is dedicated to that, who has gone through education to really understand and appreciate all the different cultures, I think is going to be like a very valuable, rather than having many different providers provide sort of more of a superficial type of a recommendation.
All right. Well, guys.